It's still experimental data, but if we are able to save 40% patients, then it's a significant, it's something that means something to real patients. So we were able to show that hydrogen sulfide acts as an inflammatory mediator in sepsis and could be a potential therapeutic target. We went on to look at what H2S does in burn injury, lung injury associated with burn injury. And what we found was, this is how a normal lung looks like. When we gave placebo, which was just a vehicle for PAG, we can see that there is a damage to histoarchitecture of lungs, and you can see that there are white blood cells, inflammatory cells that are in the lungs, and when there is treatment with PAG, there is a significant protection against lung inflammation. This work was done by my former RA, Changqing. So we could show that H2S acts as an inflammatory mediator in lung injury following burn injury and could be a potential therapeutic target for that. The question is, how does H2S act in inflammation? What is the mechanism by which H2S acts? And we have done some early studies in which we have looked at substance P. Now, there is a lot of information on this slide, but the important thing to bear in mind for substance P is that it's a mediator of pain. So when you have pain, you have, or when there is an injury, substance P can be released from nerves, and then that in turn can contribute to swelling. It can cause release of different other mediators, and we have done some work in which we have looked at substance P acting on different kinds of white blood cells, neutrophils, monocytes, macrophages, and causing release of chemokines that contribute to inflammation. We have shown earlier that substance P by itself promotes inflammation in acute pancreatitis, sepsis, and burns. But the question that we had was, does substance P do anything to hydrogen sulfide-induced inflammation? So what we did was, we injected or administered sodium hydrogen sulfide, NaHS, which is an H2S donor. So when you inject H2S donor, you see that there is an increase in substance P. So H2S somehow is causing activation of substance P synthesis. Then we went on to look at what was H2S doing, and H2S by itself could cause inflammation when we measured by looking at myeloperoxidase, which is an enzyme produced by neutrophils. These are inflammatory white blood cells that go to the site of injury, site of inflammation. So when you are measuring myeloperoxidase, what you are looking at is whether or not we have inflammation in the lung, and we do have inflammation in the lung. This is what happens in normal mice. But when we use mice that are genetically deficient in substance P, that is the pre-protachykynin A gene, there is a significant protection against H2S-induced inflammation. So when you don't have substance P, you don't have inflammation caused by H2S. And these mice were a generous gift from Professor Alan Basbaum at the University of California, San Francisco. So this showed that H2S could be contributing to inflammation through substance P. Now, is it relevant in a disease condition? And we looked at what happens in in sepsis. And this work was done by Huili again, and she was helped by Akhil Hegre, who was doing his PhD at the same time and looking at substance P in inflammation. So they both got together and did this project, and you can see Akhil in the audience here. He is presently working as a postdoc in my group here in Christchurch. Of course, try to retain the best people as much as possible. And what they did was they looked at PAG, that is blocked H2S synthesis, different approaches, or genetic deletion of substance P, or blocking of action of substance P with a specific receptor antagonist that would block the action of substance P. So using different approaches, it was shown that H2S acts as a mediator of inflammation in sepsis via substance P. Now we change direction a little bit and we look at crambine. Now, if there are any chemists in the audience, they would know that crambine, or 1-cyano-2-hydroxy-3-butene, is a nitrile. It's a plant nitrile which is found in cruciferous vegetables, for example, broccoli or Brussels sprouts. And when we give this to animals, to mice, we see that there is a protection against acute pancreatitis. This is how a normal pancreas looks like. You can see pancreatic acinar cells and some ductal cells. In acute pancreatitis, you can see that there is fluid, so there is a bit of swelling, damage to the cells, pancreatic acinar cells, and also you can see some inflammatory white blood cells. And when you treat animals with crambine, there is a significant protection against pancreatitis, and you see a lot less damage in this case. How does crambine protect against pancreatitis? It does so by increasing anti-inflammatory mediator. So interleukin-10, which is an anti-inflammatory mediator, on one hand you have pro-inflammatory mediators like hydrogen sulfide or substance P or chemokines that I referred to, and then you have the anti-inflammatory mediators such as interleukin-10. This work was done mostly by my former PhD student, Cynthia Chow, and this is the day she got her PhD, so she's quite pleased with it, but a lot of work, hard work went into it. And in the early stages of this project, Abel Amk was involved with this with the crambine project as an undergraduate trainee, and he's now moved here last week, and he is in my group as a PhD student. And as I said, you try to retain the best students as much as best people as much as possible. So what they were able to show was that there is an increase in pancreatic interleukin-10 levels with crambine treatment, and crambine could protect against acute pancreatitis by stimulating the anti-inflammatory mediator IL-10. So either you block a pro-inflammatory mediator or you activate an anti-inflammatory mediator. Now, all this research that I have shared with you so far is with experimental models of disease. And it's a fair question as to whether or not this research can translate into human disease. And the short answer is yes, we hope so, and we are looking at the translational value of this research. I'll give you an example. Some work that we did in Liverpool, we worked with cytokine-induced neutrophil chemoattractant, a chemokine, in the rat, and its human homologue growth-related oncogene alpha. And we were looking at both of them together, side by side. So in one case, we looked at zinc in a rat model of acute pancreatitis, and we found that on induction of acute pancreatitis, with cerulean, which is a standard model of induction of acute pancreatitis, there was an increase in zinc levels. And on recovery, these levels came back to normal. So there was an increase when there was acute pancreatitis. When there was recovery, these levels came back to normal. When we looked at human patients, we found that in severe acute pancreatitis, there was a significant increase in growth-related oncogene alpha levels. So on one hand, in an experimental model, we see that there is an increase in zinc levels. The human homologue of that, GRO alpha, is increased in human patients. So yes, this research is indeed, it's possible to translate this research. Some more recent research on H2S in inflammatory disease, acute pancreatitis, sepsis that I've spoken about earlier, and joint inflammation. In disease models, mouse model for acute pancreatitis and sepsis, and rat model for joint inflammation or arthritis. And we did this research in Singapore because of the excellent infrastructure available for that, and also because it was possible to do that research following best practices. We found that there was an increase in H2S in all these conditions in experimental models. Now, how about clinical situation? We have very small number of patients for each of these, but we have clear data. We did some work with colleagues in Singapore on human acute pancreatitis. We found that there was an increase in H2S levels in human acute pancreatitis, in severe acute pancreatitis. And we have worked with clinical colleagues here in Christchurch Hospital, and we find that in patients admitted to the ICU here in Christchurch, there is again an increase in H2S levels. And also in patients with, again, local Christchurch patients with rheumatoid arthritis and gout, H2S levels are increased. So the preclinical research that we have been doing is clinically relevant, and we have early results to show that it is indeed clinically relevant, and we look forward to working more with colleagues here and take this research further into the clinic. So what we have got so far, and it's an ongoing process, research is really something that is difficult to predict. It is an ongoing process, but we believe what we have got so far is that hydrogen sulfide is a new mediator of inflammation that activates substance P, and that in turn contributes to inflammation. Now these two, hydrogen sulfide and substance P, they can prove as biomarkers for the disease, and also they can serve as potential therapeutic targets or treatment strategies for inflammatory diseases. Finally, so where do we go from here? It's important that we are able to investigate the mechanism by which hydrogen sulfide and substance P contribute to inflammation, because there's a lot that we still don't know about how what goes on in the inflammatory process, and there is a lot of molecular work involved with this, and there are things that I left out of this lecture because I didn't want it to become a very technical lecture, but we do need to know how are H2S and substance P contributing to inflammation in different conditions. One of the examples is using mice that are genetically deficient in H2S formation ability. Now, these mice have recently been generated by my colleague Dr. Isao Ishii in Tokyo. And we've done a lot of research with PAG. That's very good, very useful. When you need to develop a drug, you will need a drug, you will need a chemical, but these animals are deficient, genetically deficient in producing hydrogen sulfide, and it's important that we are able to investigate mechanisms and the precise role of H2S using these mice. In the clinic, it's important to investigate diagnostic and prognostic markers of inflammatory diseases. When a patient comes to the hospital, it's important for the treating doctor, one, to be able to say whether or not this patient has the disease, and also, if possible, to be able to predict what course this disease is likely to take. And we hope that these markers that we have discussed today and more would help in that direction. We need to develop new therapeutic targets or treatment strategies for inflammatory diseases, because the treatment strategies that are available at this time, they are not satisfactory. The treatment for these conditions is, especially when it involves SIRS, it's really supportive, and that's not good enough. So we do need to develop better treatment strategies. And then we would like to extend this knowledge to other inflammatory diseases, for example, trauma, arthritis, diabetes, cancer, atherosclerosis, ischemic heart disease, and so on. Finally, I would like to thank my collaborators, those that I have worked with in the course of my research, but also, or in the course of my career, but also some of those that I've still never met, but they provided unique reagents that were very helpful in my research. And the way it works is people may know you because of your work, and you know them because of what they have done. You communicate with them, and